So we are going to start a topic that is adrenal gland. I think you all have read in anatomy, physiology, and also in pathology. You are in the final year about the details of the adrenal glands. So in this short span of 45-50 minutes, we'll just have the overview. What is really important for you in the examination and what should you know for your clinical purpose. I'm not going into the biochemical details of this gland's function because it is beyond the scope of discussion. So in today's class, what is our learning objective? Learning objective is understand the gland's anatomy and physiology a bit, recognize the types of adrenal pathology, learn diagnostic approaches and review of the treatment principles. So first of all, we will have to start with anatomy of the gland. It's a pear gland, lies just above the kidney. It's a triangular shaped, supplied by three arteries. Importance of adrenal gland, it is supplied by three arteries and drained by a single vein. Three arteries, main artery comes from the aorta itself, the middle adrenal artery. The lower adrenal artery comes as a branch of the renal artery, and upper adrenal artery comes as a part of the inferior phrenic artery. But the vein which is in the right side is a very short vein which drains into the inferior vena cava, and in the left side it drains into the renal vein. That is the anatomical peculiarity which you will understand when we dissect the adrenal gland for surgery. We'll have to look for renal vein first in the left side to look for the adrenal vein because it's a very short, stubborn vein. If there is any mismanipulation of the vein, it tears and makes profuse bleeding. That is why one must know the anatomy of the adrenal gland very precisely, which is triangular shaped, approximately 3 to 5 centimeter in length and width. And at the same time, if you go into the cross-sectional image of this gland, you can see that it has three zones. Actually, it has got two parts. One is the cortex and another is the medulla. The cortex is developed from the mesoderm and the medulla is developed from the neuroectoderm. So it is a gland which has got multiple functions and multiple secretions in relation to the clinical practice. So if you look at the cortex of the gland, it can be divided into zona glomerulosa, zona fasciculata and zona reticularis and the medulla. These are the parts of the adrenal gland which has different function. To remember it, that zona glomerulosa secretes aldosterone, which is a salt manipulating hormone. Zona fasciculata, zona fasciculata liberates cortisol, which controls the sugar of the body, and the zona reticularis, it secretes the androgen. For the remembering, we remember it as salt, sugar and sex. Salt is controlled by aldosterone. The zona fasciculata is the sugar, that is cortisol, and the fascicularis reticularis is the androgen. And the adrenal medulla, on the other hand, is a neuroendocrine organ which secretes catecholamines in the part of epinephrine and the norepinephrine. It is a part of the sympathetic nervous system. It's an isolated part of the sympathetic nervous system which secretes epinephrine and norepinephrine. If the tumor arises from this part of the adrenal gland, it produces mainly catecholamines which produces severe effects on the body, which we will discuss later on. I am starting three things you will have to remember in this adrenal gland. One is Pheochromocytoma, second is Conn's disease. These are the two very important. Another is, I will gradually tell you that first let us start with the Pheochromocytoma, which I have discussed at the end, which is the disease of the adrenal medulla. Adrenal medulla's tumor which produces severe catecholamine. I am making as a case history so that you remember the case, so that it will be easier for you to remember the clinical features of Pheochromocytoma. Suppose she is a 36 years old female. She presented with episodic headache, palpitation and profuse sweating for the last few months. So remember, a young lady presented with episodic headache, palpitation and profuse sweating. In the history of present illness, patient reports sudden episodes lasting for 15 to 20 minutes with profound headache, racing heartbeat and intense sweating occurring 2 to 3 times a week. She noticed anxiety during the recent weight loss despite normal appetite. Blood pressure has been elevated during episodes but normal in between. In the past medical history, no known chronic illness, no family history of hypertension and endocrine tumor. So remember, these are the clinical features of a standard Pheochromocytoma patient which you come across in the clinical practice. In the examination, we will see the blood pressure is raised 180 by 110 in sitting position, and the heart rate is also 110 per minute. There is no skin pigmentation, goiter, lymphadenopathy, cardiovascular and abdominal examinations are normal. This is the total clinical picture of a patient who comes with Pheochromocytoma. If you come across in your examination with this kind of a history, and as they ask you to write down what is your provisional diagnosis, you always have to remember that Pheochromocytoma is one of the major cause of this kind of clinical presentation. Next, once you get this kind of a patient, you will have to investigate the patient to establish your diagnosis. How do you establish your diagnosis? The most important examination is plasma metanephrine. As we all know, the epinephrine and norepinephrine are metabolized in the body into metanephrine, and this particular product is elevated in case of the Pheochromocytoma, which is the diagnostic clue to diagnose Pheochromocytoma. Second important thing is 24 hours urinary catecholamines, elevated norepinephrine. These are the two investigations normally done to establish whether the patient is suffering from Pheochromocytoma biochemically. Third and the most important investigation is the CT abdomen. There is 3.5 centimeter well-defined right adrenal mass. I will show you picture later on. So CT abdomen will show 3.5 centimeter well-defined right adrenal mass. An MIBG scan, it is a radionucleotide scan which uptake particularly in the presence of the chromaffin cells, proving that it is a tumor arising from the medulla. So these are the investigations which are needed for establishing the diagnosis of Pheochromocytoma. Is it clear to all of you? Do you understand? I am asking you, do you understand what I said? I am trying to make it as simple as possible for you to remember. Then what is the management of this patient? Management is to preoperative alpha blocker. We all know, all of you have read in the pharmacology how, when, what are the site of action of these endocrine, the epinephrine and norepinephrine. These are the alpha and beta receptors in the body. So we will have to block this with alpha blockage, which is the predominant site of action with the help of the phenoxybenzamin for minimum 10 to 12 days. And next, we may have to correct the fluid deficit. These kind of patients, due to hypertension, they suffer from fluid deficit, correction of the fluid deficit, correction of the blood pressure with the alpha blocker, at times beta blockers are also necessary to control the blood pressure. The ultimate result, ultimate treatment is removal of the tumor, and this is in today's life is most commonly done with the laparoscopic adrenalectomy. The histopathology confirms the pheochromocytoma, postoperative BP gets normalized, and follow up with the regular BP monitoring and the yearly plasma metanephrines to check recurrence. So this is the short note I have discussed. This you must remember that pheochromocytoma is a very common question for undergraduate level, and if you write at least this much what I have told you, you will get at least 85% marks because it contains all the salient features related to the pheochromocytoma. Next is Cushing syndrome. What is Cushing syndrome? Any of you have any idea what is Cushing syndrome? You must have read it in the pathology. তোমরা কেউ পড়োনি Cushing syndrome? Cushing syndrome is due to the hyperplasia or the tumor involving the zona fasciculata. This also I am starting with a clinical history so that you remember how they come to you. Say 42 years old female, chief complaints is progressive weight gain, facial rounding over the last 8 months. Young lady with facial puffiness and the round moon-shaped face and progressive weight gain is the first symptoms they complain when they come to the clinician. Patient reports increasing fatigue, difficulty climbing stairs, and easy bruising. She also noticed facial puffiness and red-purple stretch marks over her abdomen. Her periods have become irregular. This is the common presentation of this patient. Try to remember the history of the patient so that you don't have to mug it that what is the presentation of Cushing syndrome. What do you get on examination? You will get raised blood pressure, there will be truncal obesity and thin limbs. Limbs are thin, but the trunk is quite heavy. Moon face and supraclavicular fat, which is called buffalo's neck. Truncal obesity with thin limbs, moon face and supraclavicular fat pads. White purple striae on the abdomen and proximal muscle weakness. These are the common clinical findings we get in a patient with Cushing's disease. Now we'll have to find out, I told you it is the tumor of zona reticularis, fasciculata. So this is the area, can be ACTH dependent and it can be non-ACTH dependent. What is the importance of the ACTH dependence? That the main reason the adrenal gland is controlled by, mainly this part is controlled by hypothalamus. Hypothalamic secretion is necessary for control of this part of the gland, and it has also a negative feedback that if there is rise in the cortisol level, there is suppression of the cortical secretion. This I think all of you know that this is the most important part which is controlling the homeostasis in the body. So we'll have to find out whether it is an adrenal adenoma or it is a hypothalamic dysfunction, that is the pituitary tumor, which is causing this oversecretion of this gland. Normally 3 hormones are cortisol and corticosterone. These are the 3 hormones which are being liberated by this part of the gland, and the control is entirely on hypothalamus ACTH secretion. But there are conditions where the adrenal gland itself is diseased due to presence of an adenoma or a cancer, anything, in which case the hypothalamus cannot control the secretion of the hormone. So we'll have to find out whether it is a localized disease or it is a hypothalamic disease, for which we'll have to do certain test that is called low dose dexamethasone suppression test. There is in positive case there is no cortisol suppression. Normally, if we give steroid from outside, the internal cortisol level gets suppressed. Dexamethasone is a synthetic corticosteroid which is given to suppress the cortical secretion by the gland. But if it is an adenoma of the adrenal gland, it will never suppress the cortisol, and the cortisol level will be raised or normal, but the serum ACTH will be suppressed. This shows that patient is not having any control, hypothalamus does not have any control over this gland. Understand, is it clear to you that ACTH is suppressed but the cortisol is raised or normal, which is showing that ACTH does not have any control over this. These are the ACTH independent group, mainly the adrenal gland adenoma related to the zona, that part of the gland. So the diagnosis is ACTH independent, that is called Cushing Syndrome, that is adrenal adenoma. And if there is any pathology in the pituitary, then the ACTH will be, this phenomenon will not be present, and we will have to look for the pituitary for any adenoma which is hypersecreting and treating this problem. That case, our target will be the pituitary. The management of this is the left adrenalectomy and gradual steroid taper in the post-operative. We will have to supplement the patient with steroid once we remove the gland and gradually taper the steroid so that the homeostasis is maintained. What I have said, is it clear to you all or not? I will repeat. Tell me, is it clear to you? You understood, all of you understood what I said? Okay, so the two things, Cushing syndrome is another important short note for you in the clinics. Third is the Conn syndrome, that I said, that is the salt. First is, what we have discussed is salt control by the adrenal. Which part secretes this tumor? In which part this tumor is developed? That is in the zona glomerularis. Zona glomerularis is the area in which this tumor usually develop, and which is called primary hyperaldosteronism or the Conn syndrome. He is also a 35 years old male, presented with persistent hypertension and leg cramps. Remember, all these three cases have different presentation, but all are originated from the adrenal gland. This patient, persistent hypertension with leg cramps. Why there is leg cramps? Because of the electrolyte imbalance related to it. History is that despite triple hypertensive therapy, BP remains high. He frequently experienced muscle cramps and fatigue, no significant weight change or headache episodes. BP is 170 by 110, no signs of Cushingoid or thyroid disease, neurological examination is normal. So a young male or young female presented with muscle cramps and persistent hypertension, you will have to think of a Conn's disease. These are mainly medical part of the adrenal gland. In surgery, our role is mainly the adrenalectomy. But if you cannot diagnose the condition, you will never be able to come to a treatment conclusion of this patient. Where lies the importance of knowing these cases in brief so that you can diagnose it properly? So, what is important? Third is hyperaldosteronism and the Conn's disease. Now, how to evaluate this patient? If you take the blood report of this patient, the serum potassium is elevated, depressed. Normally, what is the level of the serum potassium? Any of you? Huh? Very good. 3.5 to 5. So, if in this case you see the serum potassium is 2.8, the aldosterone and the renin ratio is elevated. There is elevated aldosterone secretion. And CT scan shows 1.8 centimeter right adrenal mass. If you get up to this, to confirm the diagnosis, what you will have to do? Adrenal vein sampling for the aldosterone, which is not a very important clinical tool, because very rarely we can do this adrenal vein sampling. But this is the best way to establish that the patient is suffering from the Crohn's disease. Diagnosis of the Conn syndrome is established by doing these chemical examinations, and the treatment is very clear. It is the laparoscopic right adrenalectomy and BP and potassium normalized in the postoperative period. So, these are the three conditions which you will have to remember for your examination, also in the clinical practice. So, I will recapitulate everything about it, but you have to remember these three conditions related to adrenal gland. Another condition which comes, the adrenal incidentaloma. What is incidentaloma? That the patient is being evaluated. Suppose he is being evaluated for any adrenal pathology, for any stone in the kidney. On CT scan, we could find out that patient is having a mass in the adrenal, and that is what is called incidentaloma. That incidentally you have diagnosed the condition. In that case, what is our objective? Our objective will be to evaluate the size of the tumor. If the tumor size is more than 4 centimeter, we will have to take into consideration. Number two, we will have to assess the hormonal activity. What we have done in the past three conditions, we will have to rule out that whether these are those things are present in this incidentaloma or not. Understand? That incidentaloma is also a very important short note, because in which case you will have to write everything in brief. That incidentaloma may be the early presentation of a tumor which can be of any category, what I have discussed. Workup is imaging, CT, MRI and the biochemical test, cortisol, aldosterone and metanephrine. You will have to rule out all the conditions which can give rise to any of these three symptoms. So, to sum up, Pheochromocytoma symptoms is the classical triad, that is headache, palpitation, sweating, paroxysmal hypertension and panic attack. Diagnosis is plasma-free metanephrines or 24 hours urine metanephrines. Imaging is CT, MRI or MIBG scan. This is the sum up of this entire story. And pheochromocytoma management is preoperative alpha-blockade with phenoxybenzamine or adrenal, that is a beta blocker, and laparoscopic or open adrenalectomy. Next is Cushing syndrome. It is due to the excess cortisol production ACTH dependent versus ACTH independent, which I have discussed. You understood? And Cushing syndrome symptoms are moon face, truncal obesity, striae, weakness, osteoporosis, hypertension. Diagnosis is low dose dexamethasone test, assess ACTH level, adrenal pituitary imaging. As I have said, to rule out, these are the investigations you need to do. This you will have to remember for your examination. And the Cushing management is adrenalectomy if the adrenal tumor. Treat underlying cause in pituitary or ectopic ACTH. Ectopic ACTH, there are certain tumors which is neither in the adrenal nor in the pituitary, like in the lungs, in the prostate, small cell carcinoma of the lung, cancer prostate at times secrete ACTH like hormones. So we'll have to localize from where it is being secreted when the lungs, where the pituitary and adrenal can be excluded. So ectopic ACTH, if there is pituitary tumor, you will have to treat the pituitary tumor, and adrenalectomy if the adrenal tumor is present. Conn syndrome overview, it's the primary aldosteronism, usually adenoma, causes sodium retention and potassium loss. Remember, the role of this aldosterone is retention of the sodium and the potassium loss, and Conn syndrome is usually present with hypertension, hypokalemia, weakness, aldosterone and renin ratio rise in the aldosterone and the renin ratio and the adrenal vein sampling. And management is unilateral adrenalectomy if localized, and spironolactone treatment. Spironolactone is a potassium sparing diuretic which is being used to treat if it is a bilateral hyperplasia of the gland. Next comes the adrenocortical carcinoma. Adrenocortical carcinoma is rare, often functional, aggressive, may produce cortisol, androgen, estrogen, any of the hormones it can produce because it infiltrates all the layers of the adrenal gland. The diagnosis is mainly large invasive mass in the CT scan, surgical excision open or laparoscopic if possible. If the tumor is small, may be attempted, but the prognosis is very bad. All these conditions I have discussed, that prognosis is reasonably good. But this condition, adrenocortical carcinoma, which usually present in the later half of the disease and the prognosis is basically very bad. There is very little medical management for this condition. Debulking of the tumor may have been attempted, but the results is not satisfactory. So long we are discussing with the unilateral adrenal mass, which is the most frequent condition. But there are certain conditions where it may be bilateral adrenal mass. What will you do in this case? These are usually associated with certain hereditary symptoms, out of which main 2A and 2B, von Hippel-Lindau's disease and neurofibromatosis. Have you read this MEN1, MEN2 in stomach? Huh? Yes. It is a part of it. It's a multiple endocrine neoplasia. Type A, 2A and 2B are commonly associated with adrenal mass. And von Hippel-Lindau's disease is a disease of neurological origin, can be associated with some renal and the adrenal pathology. And the neurofibromatosis is a generalized neurofibromatosis in which the adrenal can also be a part of it. Adrenal. So these are the commonly familial and may present as a bilateral adrenal mass. So to summarize the entire thing, I am placing today's class considering your examination. Try to remember in brief. Some part of the adrenal in the theory will definitely come in your final MBBS. So don't forget, Pheochromocytoma hormone is catecholamine. Key features is episodic hypertension. Treatment is surgery and alpha-blockade. Cushing, the secreting hormone is cortisol. Miss Abha, I'm in a class. I will call you after 10 minutes. Okay. So Cushing, the cortisol. Key features is obesity and striae. The treatment is adrenalectomy. And the Conn's disease, the hormones is aldosterone, hypertension, and the low potassium is the treatment. Adrenalectomy and medicine may be the treatment of choice. This you remember, this chart you must remember to combat all the conditions related to the adrenal gland. And thank you for the kind listening, because I have made this very precise for you all. Now you tell me if you have any question, I am ready to answer. Okay, come to a clinical question. If the patient is having bilateral adrenal disease, if you remove the bilateral adrenal gland, is it possible for a man to survive? Is it possible for a person to survive? These are the questions they will ask you in the examination. They will not ask you, tell me the zona glomerulosa. These are the questions. Is it possible to survive if you remove both the adrenal glands? Yes, it is possible. You will have to supplement. You will have to supplement the person with, because bilateral adrenalectomy is also a condition which may be necessary at certain condition. So it is not impossible for a person to survive with bilateral adrenalectomy, but there will be tremendous risk if the hormonal imbalance takes place. You will have to be very careful. Third question which may be asked: suppose a patient has come with the lump in the left upper quadrant. What are the differential diagnosis? I am asking, it is present in the right upper abdomen. Left upper abdomen. What are the differential diagnosis? Splenomegaly, good. Then left quadrant, gastric. Okay. Left upper quadrant, yes, gastric is a possibility, but you will have to think of much important organ. Kidney, you will have to think of the renal mass, which is the most common mass in the left upper abdomen after splenomegaly. So how will you differentiate it between a renal mass and adrenal mass? Clinically, okay, this I agree. Imaging and biochemical evaluation will tell us, but clinically, how do you suspect that it can be adrenal mass? I cannot hear you. Renal angle tenderness. Renal angle tenderness is mainly if there is inflammatory condition, then we will get renal angle tenderness. Suppose the hydronephrosis, do you get renal angle tenderness? No. So, mass moves with respiration. Understand? What is the benign tumor of the adrenal gland, which I have not taught you? Myelopoma, which I have not taught you. That is why I have kept free to tell you all this. Myelopoma, which is the commonest benign tumor of the adrenal gland, and if it is less than 4 centimeter, normally no treatment is necessary. But if it is more than 4 centimeter, you will have to take off removing the tumor, because it may convert it has a malignant potential. It has a malignant potential. Okay. Have you seen, or in any part, have you seen how the adrenalectomy is done? Because YouTube is not allowed to show you in the class, that is why I cannot show you, and I don't have my recorded adrenalectomy operation with me right now. It's all lying in my previous medical college, and they will not hand over. So, do you know how it is done? It is mostly done intraperitoneal approach by laparoscopic method, 3 ports. 1 port at the level of the umbilicus, 1 port in the subcostal, and 3rd port in the, suppose I am talking about left side, 3rd port in the spino-umbilical line. These are the 3 ports we make, and we reflect the colon anteriorly, including the splenorenal ligament, splenocolic ligament. We reflect everything anteriorly. We look for the renal vein. Once we look for the renal vein, we look for the upper border of the renal vein to look for the adrenal vein, because adrenal vein, I said at the beginning, the adrenal veins drain directly to the renal vein. If you can dissect the renal vein, you will get the adrenal vein, clip the adrenal vein at the beginning and make the gland free. All those 3 arteries which are supplying to adrenal glands are very thin arteries. So, if you can control the renal vein and dissect the gland gradually from the medial margin, which is overlying partly the kidney and partly the structure related to tail of the pancreas, you will gradually release it from the medial end, and then you remove the gland from the superior surface of the kidney and lift the gland up so that you get a cleavage to remove the adrenal gland. But the danger lies in the right side. In left side, the anatomy is established that it will drain into the renal vein, adrenal vein. But in the right side, it drains into the IVC itself, and it's a very short vein. Very short vein. If there is little mishandling while dissecting the medial end of the adrenal gland along with the IVC, it gets torn and torrential bleeding takes place. So you have to be very careful while you are doing right adrenalectomy. Okay. I think this is enough for today. Are you all at least understood what is adrenal? It is not possible to teach everything in adrenal, but the basic overview, what you should remember, the 3 conditions, the minor operative details of it, and the control of adrenal by hypothalamus, control of adrenal by itself, that some tumors are self hormone producing, and some are produced by the hypothalamus control. These you must remember, which are the ACTH dependent, which are not ACTH dependent. You will have to remember the Cushing syndrome. Cushing syndrome, patients comes to you with puffy face, buffalo neck, there is hirsutism, you can make out of, if you see the picture of a Cushing syndrome person, you will never forget that patient is suffering from the Cushing, and you will see the easy bruising. You just hit her with a small pain, you will see there is a bruise on her hand. So these are the features you must remember all over. In Conn syndrome, the muscle cramp, you will see many of your family members say they get muscle cramps at night. Try to find out the electrolytes of this patient. Try to find out the electrolytes of this patient. You may get a borderline potassium. You may get a 3 potassium, which is not very low, but patient starts having symptoms. So these are the clue I am giving you, should be remembered while treating a patient which has come with this kind of symptoms. Okay.